Hi, good evening, everyone. I'm Amit Shukla from Sun Pharma. I would like to extend a very warm welcome to all the viewers for the webinar on the management of active and bleeding hemorrhoids. Thank you all for taking time out and being here today. We at Sun Pharma is committed for long-term partnership with medical fraternity by providing continuous information, update, and solutions for various disease conditions. And this webinar is a step towards the same. It's indeed a pleasure to have Dr. Somed Das with us as a speaker. Dr. Somed Das is a senior surgeon in Netaji Subhash Chandra Bose Cancer Hospital, Kolkata. I would like to convey on behalf of Sun Pharma my sincere gratitude to Dr. Somen Das for accepting our request to become a guest speaker for the webinar. I'm quite confident and sure that all of you are really going to be enriched with a lot of valuable information about the management of active and bleeding hemorrhoids post this session. So, without taking much of your time, I would like to invite and welcome Dr. Abbas, Dr. Komel Abbas from the medical team of Sun Pharma. So, I would like to welcome Dr. Komel to officially introduce and welcome Dr. Somed Das. So, over to you, Dr. Komel.
Thank you very much. Thank you, sir. It gives me great pleasure to extend to you all a very warm welcome on the behalf of Sun Pharma for today's Aldospin Conclave webinar on hemorrhoids. At Sun Pharma, we believe in connecting eminent faculties from around the world for exchanging their skill and experiences with each other, which in turn benefit the patients. Today's webinar is one of the such event. With this opportunity, I take this opportunity to welcome today's speaker, Dr. Somen Das. He is currently head of the surgical oncology, Netaji Subhash Chandra Bose Cancer Hospital, Kolkata. He is ex-associate professor of surgery, IPGMER, Kolkata. He has passed his medical and post-graduation with gold medalist. He has done FACS from USA, MRCPS from Glasgow. He has also done many qualifications in colorectal surgeries like FMAS, FIAGES, FALS. He is also UICC fellow in surgical oncology from TMH Hospital, Mumbai. He is also IACA fellow in robotic cancer surgery from COH Hospital, USA. So he has many qualifications in surgery. His area of interest are cancer surgery, breast surgery, colorectal surgery, and advanced laparoscopy surgeries. With this short introduction, I request Dr. Das to take the session forward. Over to you, sir.
Thank you. Thank you, Dr. Abbas. Is my slide visible to everyone?
Yes, sir. Yes, they are very clear.
So today we shall be discussing on the bleeding hemorrhoids. I have intentionally added the management of constipation along with it because most of the times we deal with them together. Okay, now I bring greetings from my institution, that is the Netaji Subhash Chandra Bose Cancer Hospital, Kolkata. This is a pioneer institute in Eastern India which deals with cancer and colorectal diseases. Now, why are we discussing constipation and bleeding per rectum together? Let us begin with the tale of two patients. Patient 1, who is at 65 years gentleman, presented with constipation, pain during defecation for last 3 months. And patient 2, Mrs. Y, a 40 years housewife, presented with constipation with occasional bleeding per rectum. Now, these are the pictures of these two patients. The patient 1, you have a sentinel tag on the outside. You diagnose the patient as Fishery Nano, considering the pain and the bleeding per rectum. On the second patient, you see in the lower part, these are the perianal warts. So you make a diagnosis of perianal warts, you don't find anything inside. Okay, what you do? Both these patients you put on diet restriction, that is high fiber diet, lactulose and Sisbath. Okay, both these patients, they recover very well. 3 months down the line, The first patient, they don't have, both the patients, they don't have any pain, but they're still constipated and few occasional bleeding per rectum. The second patient is doing absolutely fine. Okay. Now 6 months down the line, both the patient comes back again. And now the first patient is having bleeding pair, which is more severe than initial part, and the second patient is having constipation. Okay. Now you investigate and you do a colonoscopy. In the first patient, you find there is a large ulceroproliferative growth in the rectosigmoid. The second patient colonoscopy is normal. In addition to that, you do a CT scan in the first patient, you find multiple inoperable liver mets. So you see the first patient, now the question is what do you do? Because it has now become a colon cancer with multiple liver mets. So what went wrong in these two patients? Actually, what you have done, you have ignored the bleeding per rectum and you have ignored the constipation. So if we have taken care of the constipation and the bleeding per rectum properly by doing proper investigation, we could have avoided this situation of getting liver metastasis in a patient of colonic cancer. So what I would like to emphasize upon that constipation or hemorrhoid, these can be a secondary manifestation of a colon cancer inside. So one has to be very meticulous in preparing this patient and investigating this patient. So let us look at the first part, that is the constipation. What is a constipation? Now, way back in 1980s, Whitefield has proposed a criteria for constipation. It is the straining, it is the feeling of incomplete evacuation, and hard stool in more than 25% of your bowel movements. And bowel movement frequency, when it is less than 2 per week, we call it constipation. But as of now, we actually depend on Rome 3 criteria for constipation, which says when you have 2 out of these 6 criteria, that is training, hard stool, incomplete evacuation, use of digital maneuvers to take out the stool, okay, sensation of anorectal blockage, and less than 3 movements per week. So I repeat, there is training, hard stool, incomplete evacuation, use of digital maneuvers to take out the stool, sensation of anorectal blockage, and less than 3 movements per week. We call it a constipation. So any 2 of these 6 criteria, if it is present in any patient, then we stamp the patient as a real constipation. Okay, there are other scoring systems, but till date we believe in Rome 3 criteria. We use Rome 3 criteria for treatment purpose also. Now, in a patient with simple constipation, if the patient comes with only constipation without any bleeding per rectum, without any other perianal problems, now are the investigations essential? The answer is yes, because no patient complaining of constipation should be considered to have functional cause of constipation until and unless you rule out all the structural and colonic causes of constipation. So, in a nutshell, investigations are essential in a patient with constipation. Now, this slide is very important. When we deal with constipation, the causes can be extracolonic, it can be colonic. Okay. Now, the extracolonic, you may have drugs like anticholinergic drugs. You may have metabolic and endocrine diseases like diabetes, hypothyroid. You may have some neurologic diseases like Parkinson's disease, etc., which can cause constipation. So here, colon is not at fault. So here, something outside the colon is controlling this constipation. Okay. So these are the extracolonic causes. Whenever a patient comes to you with constipation, you have to exclude the extracolonic component first. Okay, you take the history for drugs, you take the history of any metabolic or endocrine diseases, any neurological diseases patient is going through. Okay, so when the first part is excluded, then you look at the colonic cause of the constipation. Okay, in colonic part we have 2 things. One is a structural, another one is non-structural. If if the structural one is the cause, then it is mostly a secondary cause arising from the colon. That means the cancer, hernia, adhesions, or hemorrhoids. Remember, hemorrhoids can be cause and effect of constipation. Okay, hemorrhoid can be an effect of constipation and it can give rise to constipation also. So when you have these structural causes, these are actually the secondary causes of constipation. You have to take care of these particular causes and the constipation is going to go down automatically. Okay, after you have excluded this part, then comes the role of non-structural causes of constipation. The last is the functional one. When you don't find any cause of constipation, then you call it's a functional constipation. Now, one neglected but important part is the idiopathic part of constipation, where the cause lies inside the colon or in the pelvis. Either the colon is not moving properly, that is a colonic inertia, we also call it slow transit constipation, or the pelvis, where the colon is moving but the pelvis is obstructing the movement of the colon or the rectum and thereby causing the constipation. Okay, and these two portions, you won't believe, at least they cater 25 to 30% of the all constipation patients, and this is the most neglected one because we don't even diagnose them. Okay, so how to approach a patient with constipation? As I told you, first you rule out this extracolonic cause, then you rule out the structural cause, then you go to the non-structural causes. Okay, how do you rule out this extracolonic cause? By ruling out, by taking simple history. How do you rule out the structural causes? You do an ultrasonography abdomen, you do a colonoscopy or double barrel barium enema. So standard of care to rule out the secondary or structural causes is colonoscopy. Okay, so what investigations? You first rule out the structural causes, as I told you, by doing a colonoscopy or a double barrel double contrast barium enema. Barium enema is not routinely practiced these days, so colonoscopy is the standard of care. Okay, especially when you have these red flag signs, that is the onset of this constipation after 50 years, there is hematochezia or melena along with constipation, there is unintentional weight loss, there is anemia or neurological deficit. When these five symptoms are there along with constipation, these are called red flag signs, and the colonoscopy is a must. Because if you miss any one of them, this can be a feature of underlying malignancy inside the colon. Okay, if they are normal, so if your colonoscopy is normal and if there are no extracolonic causes of constipation present, then you put the patient on 6 months trial of fiber supplements and dietary measures. Okay, so you have a time. First, your duty is to exclude the structural causes, then you get a time to put the patient on dietary measures. Okay, if even after 6 months of dietary measures the patient still complains of constipation, then what you do? That means this is the time when we are suspecting, as I told you, non-structural colonic causes. That means either the colon is not moving properly, that means colon is inertic, or colon is not having a normal transit. Okay, or there is some obstruction in the pelvis, either in the form of rectocele or in the form of obstructive defecation syndrome. I'll come to that. So these are the three investigations which are not routinely done, but in a patient with constipation who complains of, I repeat, who complains of constipation even after 6 months of an anti-constipation therapy, that is fiber and dietary measures, and you have excluded structural causes by doing a colonoscopy. Here comes the role of these three investigations. What are those? One is a colonic transit time, another one is difficography, and another one is anorectal manometry. So first you do a colonic transit time. What is that? Colonic transit time will tell you how the colon is moving. So what we do, we give the patient one simple tablet containing 24 radio opaque markers or siege markers. So patient is going to ingest that, and you take serial images, just simple abdominal x-rays till 5 days. Okay, and if you have the presence of those markers inside the colon, at least 20% or more than 20% of what you have given, that means we have given 24. So if 24% or more than 20% radiopaque markers are present inside the colon, even after day 5, that means the colon is not moving properly, and it is called colonic inertia, also known as slow transit constipation. That means colon movement is not there. See here, if this picture is present after day 5 in a patient who has ingested those seized markers, that means multiple seized marks are present even after day 5, it indicates the colon movement is not there. So this is called colonic inertia. Okay. Manometry is an investigation which is done to measure the pressure inside the rectum and anal canal. Okay. Difficography is an investigation. Difficography can be done fluoroscopy guided, it can be done MR guided. So MR guided is called MR difficography. Here the patient actually the simulation of the defecation process is taken, or the patient is ingested or given some dye material inside the rectum, and patient is asked to defecate in front of the fluoroscopy machine, and you see the rectal and other structures. So this is a normal difficography where patient has a full rectum, then this is a resting phase, then the patient contracts the rectum and this angle becomes straightened, and this is the post defecation when the whole of the content goes out out of the anal canal. Now see, this is one particular picture during evacuation. What happens? There is anterior bulge inside the vagina or the bladder wall. We call it rectocele. Okay, we call it rectocele in case of females. So this is one cause of constipation, very common but very often missed. Next is this one. This is a typical, but this is relatively rare. That is paradoxical puborectalis contraction. Puborectalis is a muscle. It actually acts as an anorectal sling. So this muscle covers the anorectal junction. When we contract for defecation, this muscle actually should relax. And if you see, this angle is called anorectal angle. This is the rectum, upper part is the rectum and the lower part is the anal canal. Okay. So this angle becomes straightened when we defecate. But puborectalis, if it acts paradoxically, that means during the act of defecation, if the puborectalis doesn't relax, it contracts rather, then this angle becomes more acute and patient is unable to defecate. Okay, so paradoxical puborectalis contraction is an condition where you have non-relaxation of the puborectalis during the act of defecation and patient feels constipation. Okay, this is relatively rare, but we often get these conditions also. Now, how to approach a patient with constipation? First, you exclude extracolonic causes, rule out structural cause by doing a colonoscopy. If your structural cause is not there, you put the patient on fiber supplements, laxative for 6 months. If there is no response, then you do 3 studies: colonic transit study, difficography, and anorectal manometry. If your colonic transit study, all 3 trial studies are normal, then we call it normal transit constipation. This is a common cause of functional constipation actually. So before you stamp a patient as functional constipation, you have to do at least these 3 studies. Another situation can be abnormal colonic transit study, and there is normal anorectal manometry and difficography. This is a situation where actually colon is not moving. We call it slow transit constipation or colonic inertia. When you have a normal colonic transit time but abnormal difficography or anorectal manometry, this is a situation where there is pelvic outlet obstruction. There are 3 situations, 3 or 4 situations which can give rise to this condition are rectocele, sigmoidocele, retrorectal intersusception, or paradoxical puborectalis contraction. Okay, so another situation is when you have abnormal colonic transit time and abnormal difficography, then it's a combination of slow transit constipation along with pelvic outlet obstruction. So this is a bad situation to deal with actually. Okay, now how to treat this whole part of constipation? Actually, when we go to the treatment of constipation, we need to remember one important cause and effect of constipation, that is the hemorrhoid. Now, what is hemorrhoid? Hemorrhoids are the vascular structures inside the anal canal. In normal state, they act as cushion inside the anal canal. When they become enlarged and symptomatic, when they come down, it is called symptomatic hemorrhoid. Okay, so if we look at the anatomy of hemorrhoid is better understood by when we understand the anatomy of anal canal. Okay, so this is the anal canal. The length of anal canal is around 3.8 to 4 centimeter. Okay, we divide the anal canal into three parts. One is the upper, then the middle or the transitional zone, and the lower portion. Okay, all these three, they are divided by two important lines. One line is a dentate line, which is actually the embryological line near the anal canal. So the area above the dentate line is developed from the endoderm. The area below or distal to the dentate line developed from ectoderm. Okay, that is why this area below dentate line is covered by squamous epithelium. The area above the dentate line is covered by columnar epithelium. Okay, now this transitional zone and the lower zone of the anal canal, they are divided by a line called Hilton line. The typical peculiarity of this lower zone is you have a keratinized squamous epithelium there. That means it looks like skin. So this line is actually the line between the skin of the anal canal and non-keratinized part of the squamous epithelium. Okay, why I am discussing this embryology here? Because you see the area above the dentate line is developed from endoderm. That is why it is supplied by autonomic neural system. That is why anything arising out of this is painless. So any hemorrhoid arising from above the dentate line will be painless, and we call it internal hemorrhoid. Any hemorrhoid arising below it, we call it external hemorrhoid, because they are painful, because this area which is developed from ectoderm is innervated by cutaneous nerves called pudendal nerve, branch of pudendal nerve. Okay, so that part is clear now. Now, if we look at the level of dentate line, what happens? There are multiple columns. We call it anal column of Morgandi. Now, these columns, they are numbered as 6 to 10 columns are there. Along with these, three among these multiple columns, they are little larger, and they are typically located along with the distribution of the superior rectal artery. Now, this part of rectum and anal canal, which is supplied by the autonomic neural system that is developed from the endoderm, receives its blood supply from superior rectal artery. The superior rectal artery comes and gives two branches, left and right. The right branch again divides into two, anterior and posterior. So these cushions, anal cushions, which are larger in size, they remain in these three fixed position. If we take a look from the lithotomy position, then we'll have 11 o'clock, 7 o'clock, and 3 o'clock position, 3 to 5 o'clock position of these anal cushions. Okay, they remain in the position of the superior branches of the superior rectal artery. Now, it is interesting to note that these anal cushions are normal. When they enlarge in size or when they drop down, they bleed. This is called hemorrhoid. So in other words, we all have hemorrhoids or anal cushions. When they become symptomatic, we call them hemorrhoid. Is it clear? So anal cushion is a normal part of our anal canal, which when becomes symptomatic, we call it hemorrhoid. So it's a pretty common disease. Okay. Now, when we think about a hemorrhoid, it is not only a blood vessel. These blood vessels, they have arterioles, they have venules, they have arteriovenous communications, they have connective tissue support, and they have smooth muscles. We call it Tread's muscle. The function of this muscle is they keep the hemorrhoidal cushion or the anal cushion intact. They don't allow it to fall down. Okay. When due to repeated effect of inflammation and other processes, this Tread muscle becomes loosened and the hemorrhoid prolapses. Okay. Now we need these hemorrhoids or anal cushions. Why? Because they are necessary to sense the fullness or the pressure inside the anal canal. Okay. They are very important to perceive the anal contents. They are the support of anal closure, because unless and until we have anal cushions, the anal canal will not close properly. Okay, and remember, anal cushions along with the anal columns, they are very important for the continence. So many patients, when we do hemorrhoidectomy, especially all three circumferential hemorrhoids are being removed, these patients may develop incontinence to at least flatus later on after the surgery. Okay, now these are the normal functions of anal cushions and hemorrhoids. Now how do we classify hemorrhoids? They are classified in two ways: one based on their position, and another one based on their symptoms and grade. Okay, based on their position, we divide them into two groups: internal and external. The internal, as I already told you, develops from the part of the anal canal which lies above the dentate line. Now that above the dentate line area is innervated by the autonomic neural system. That is why these internal hemorrhoids are not painful. Okay, they have the three typical locations based on the branches of the superior rectal artery: 3 o'clock, 7 o'clock, and 11 o'clock position. External hemorrhoids, they develop from the ectodermal part. That is why external hemorrhoids are painful. And remember, these areas, we don't have superior rectal supply. This is supplied by the inferior rectal artery, which is a branch of pudendal artery, and that is a systemic circulation, not a portal circulation. Okay, so they don't have any fixed position. So external hemorrhoids can occur at any place, and circumferential hemorrhoids are commonly external hemorrhoid. Okay, so I think that this part is clear. Internal hemorrhoids are painless, external hemorrhoids are painful. So internal hemorrhoids commonly presents with painless bleeding, but external hemorrhoid, they will present with painful bleeding. Okay. Now they are again classified into four groups based on their symptom. Grade 1, 2, 3, 4. Grade 1 is when the hemorrhoidal mass is present at the level of the dentate line, or it comes below the dentate line. Okay, but there is no prolapse. That means these patients will present to you with bleeding per rectum. When you examine, you will find there is small internal hemorrhoid without any prolapse. So this is grade 1 hemorrhoid. Clear? Grade 2 hemorrhoid, when you have a prolapsed hemorrhoid, when the patient strains, the hemorrhoid comes down, but spontaneously it goes up. After the straining is over, the hemorrhoid goes up. Okay, so this is grade 2. Grade 3, when you have or we call it tertiary hemorrhoid, the hemorrhoid during straining, it prolapses outside the anal canal. It doesn't go spontaneously. Patient has to push it upwards, so it requires manual manipulation to reduce it. Okay, that is called tertiary or third degree hemorrhoid. Fourth degree hemorrhoid, when you have a hemorrhoid which is prolapsed, you cannot manipulate it to reduce. Okay, so it is also known as irreducible or prolapsed hemorrhoid. So that is grade 4. Now, our Colorectal Association of India, we have proposed a new classification, or rather an addendum with the previous classification. What? Along with the grade 1, 2, 3, 4, these are almost same. We have subclassified each group, again subclassified into A, B, C, D, based on the number and the circumferential involvement of the piles. Okay, grade A is when you have a single pile mass. B, when you have two pile mass, but they involve less than 50% of the anal circumference. C is when you have a more than half circumference involvement of the anal canal. That means more than 50% of the circumference is involved by the anal canal. Okay. Grade D is a thrombosed or gangrenous spines. It can be internal, it can be external. When it comes up and the blood supply is blocked, it becomes thrombosed. Okay, so along with 1, 2, 3, 4 grade, we have subclassified them into A, B, and C or D. Why they are important? Because all these grades will dictate the management plan. I will come to that later on. Okay, that is why it is important to note, and it is important to do a proctoscopy and to see which grade the hemorrhoid is, because that will dictate your management plan. Okay. Now, if we look at the epidemiology of hemorrhoid, they are pretty common. We have 50% of population at the age of 50 who suffers from hemorrhoid. Now, as I already told you, that we do have anal cushions inside our anal canal, but when they enlarge, engorge, and become symptomatic, we call it hemorrhoid. Okay, so 5% of population at any point of time will have hemorrhoid. Okay, there is no sex predilection; male, female, both are equally affected, with some preponderance towards male in some studies. What are the risk factors? Increasing age, because the trich muscle that becomes loosened and the hemorrhoid prolapses. So this is a natural phenomenon. Okay. Prolonged sitting, straining, constipation, diarrhea, pregnancy, or pelvic tumor. So hemorrhoid can be primary when you don't have anything inside the abdomen which has caused this hemorrhoid, but the hemorrhoid is occurring. It's called primary. Secondary means when you have a pelvic mass which presses on the superior rectal vessels and the venous drainage doesn't occur properly, then this hemorrhoid can occur. A colon cancer or rectal cancer can present as hemorrhoid also. Okay, these are called secondary hemorrhoids, which compresses on the hemorrhoidal blood supply, and it increases the venous, decreases the venous return, and the vein engorges, and there is hemorrhoid formation and bleeding per rectum. Okay, so it is important to do a proctoscopy at least, and a colonoscopy or sigmoidoscopy if necessary in patients with recurrent bleeding per rectum with hemorrhoid. Okay. Now, pathogenesis, I have already discussed. There is loosening of the connective tissue. There is dilatation of the vessels and hemorrhoidal quotient, which gives rise to inflammatory mediators, and there is fragility of the wall of the venules or arteriovenous communication. Thereby, it slaps off and there is bleeding. Okay. Now, clinical features. 40% of hemorrhoid, they are asymptomatic. We will have an enlarged hemorrhoid without any bleeding, without any constipation, without any problem. Rectal bleeding, painless for internal, painful for external, is the next common feature. Mild fecal incontinence can happen, irritation and itching in the perianal skin, and sometimes when it prolapses, patient can feel a lump in the rectum or anal canal. So these are the different clinical features picked up by a study. How do we diagnose? First, you take a proper history. See whether it is a painless bleeding or a painful bleeding. Remember those red flag signs I told you: age after 50 years, recent onset bleeding per rectum, having hematochezia or melena, unintentional weight loss. All these features, if you have, then suspect a secondary hemorrhoid. So do a clinical examination, do a proctoscopy at least, or you refer the patient to a surgeon who will do a proctoscopy. Remember, proctoscopy is mandatory in all patients of hemorrhoid. Okay, you can start off with some conservative measures, you can give some medications, but you must do a proctoscopy in a patient of hemorrhoid, because you can miss on one rectal cancer or retrorectal intrasusception. There are millions of causes of bleeding per rectum there inside the anal canal, so you have to exclude those causes. Okay, so that is how you diagnose. And how do you treat hemorrhoid? There are two different modalities of treating hemorrhoid. One is conservative, to bring down the hemorrhoidal bleeding and to reduce the edema. Okay, and another one is definitive. Definitive can be done as office procedure. It can be done as a surgery, which can be moderate to major. Okay, what are the conservative measures we can have? We can have dietary or lifestyle modifications. Medications for symptomatic relief, it is for painful hemorrhoids. Sometimes it reduces the edema, and there are some venotonic drugs, I'll come to that, which will improve the hemorrhoid actually, which can reduce a grade 3 hemorrhoid to grade 2, which can reduce a grade 2 hemorrhoid to grade 1. Okay, and sometimes it can cure. And even these medicines, if they are used along with surgery, the outcome is always better. You can use add pre-surgery, during surgery, and the post-surgery to get a better outcome. Okay, Seizbath. These are also some conservative measures. Okay, so what dietary modification we take? 20 to 30 gram of fiber is recommended per day. Plenty of water is recommended, 1.5 liters to 2 liters, and if it is not contraindicated from renal side. So straining and lingering the toilet use. Nowadays, what we do, we take the mobile with in our hand and we sit on the commode. We check WhatsApp, Facebook, messages, and etc. And we prolong the toilet time. So that is not recommended. It will increase the straining and it will increase the hemorrhoid grade. Okay, regular physical exercise is recommended. Some medications which will cause constipation, it's better to avoid unless and until it is strongly recommended by the physician for some other reason. Limit intake of fatty food and alcohol because they can exacerbate constipation. Judicious use of laxative is recommended. It's not that you make the patient habit of taking laxatives day to day. Okay, some bulking agents, bulk form like ishpagula and etc. can be used. Okay, seize bath is one important thing which will relieve the pain, which this is basically nothing but the application of moist heat in the perianal area. What will do, it will reduce the inflammation, edema, and it will relax the anal sphincter. So this is a best treatment for anal fissure. It also acts in hemorrhoid because it reduces the edema, it reduces the anal sphincter tone. So if you have a prolapsed hemorrhoid, especially external hemorrhoid, then the pain will be reduced. It increases the anal asepsis and thereby it relieves irritation, pruritus. Portable bowls are now available, so patient can take seize bath very, very comfortably. Okay. Now, what are the medications we use for hemorrhoid? Remember, we can use some topical analgesics and steroids to reduce reduce the symptoms out of hemorrhoid, but those are not well studied. Okay, we have some venoactive agents. There are a lot of studies now going on, and we have results with us of various studies which says venoactive agents are good and they can be used judiciously in hemorrhoids. Okay, antispasmodic agents like nitroglycerin, they are commonly used for fissure because in fissure we have increased sphincter tone. They are used to reduce the sphincter tone, and they are very good in fissure in ano. They can be used in prolapsed hemorrhoid because prolapsed hemorrhoid you will have pain because of the increased sphincter tone, which will compress on the prolapsed hemorrhoid. So if you relax the sphincter a little, the pain relief is better. Now, what are the venoactive drugs we have? We have flavonoid group, we have others like calcium dopisilate and etc. In flavonoids, we have micronized purified flavonoid fraction, diosmin and others. So what they do, they will improve the venous tone, they will improve the microvascular permeability, lymphatic activity. Now, by doing this, they are actually curing the hemorrhoid or at least converting the hemorrhoidal grade from a higher to a lower one. Now, if you get a patient primarily who is actively bleeding, who is having diagnosed hemorrhoid, you can start off with these medications to bridge the time for or to get the time for surgery. It has been established that if they are used before, during, and after the operation, the results are better. And at times, if you have grade 1 and grade 2 bleeding hemorrhoid, these flavonoids only, they when they are used along with dietary modification and anti-constipatory mechanisms, they can bring down the bleeding rate and they can even cure the symptoms from hemorrhoid. Okay. Now, what surgery we do and when do we do it? Now, rubber band ligation and sclerotherapy, these are office procedures. What happens if you have a prolapse hemorrhoid like this? You just put a rubber band here. Okay. Now, this rubber band will cause necrosis of the distal portion of the hemorrhoid and it will slough off. Okay. So that is how you are taking care of the hemorrhoid. But problem of this rubber band ligation is the patient can develop perianal sepsis. It is often painful if you apply rubber band for an external one. So external one, there is no scope of rubber band ligation. It is applicable for only internal hemorrhoids. Okay, sclerotherapy sometimes used at the base of the apex of the hemorrhoid. It will occlude the vessel there and it can reduce the hemorrhoidal mass. Classical Milligan-Morgan hemorrhoidectomy is there, and it is the gold standard operation till date. There are some newer operations like a stapled hemorrhoidopexy, where you remove a part of hemorrhoid and you suture it or staple the hemorrhoid, the submucosal area there up in the rectum. So it will reduce the hemorrhoidal mass and it will cure the disease. There are some other options also like Doppler guided ligation of the vessels, Shivate procedure and other procedure. All these are based on the principle to reduce. These are non-excisional hemorrhoidal surgeries. They will block the arterial and venous communications there inside the anal canal, and it will reduce the hemorrhoidal blood flow. Thereby, the hemorrhoid will shrink down. Okay, so this slide is again very important. As I told you previously, the management of hemorrhoid actually depends on the grade of the hemorrhoid. So if you have a grade 1, grade 2, you start off with diet, lifestyle modification, and you can add flavonoids along with this dietary modification and lifestyle modification. If they respond, they fine. If they do not respond, then non-surgical office procedures are sufficient for grade 1 and grade 2. Most of the grade 1 will respond to this. Some of the grade 2 will not respond to office procedures. Then you go for surgical procedure. Grade 4, you bridge the time for surgery with some other measures, but surgery is the call of the day. Okay, so grade 4, the final treatment is a surgical treatment, be it stapled hemorrhoidopexy, be it Milligan-Morgan operation, whatever. So grade 4 hemorrhoid, there is the absolute role of surgery. You can start off with these conservative measures to buy time actually. Okay, some patients, they are on clopidogrel, they might have some anesthetic problems. These patients, you can buy time by applying this medication. Grade 3 is actually a dark zone where you can start this conservative method and go for office procedures, and some patients will directly require surgery, those who do not respond to office procedures and conservative measures. So this is the slide which actually in a nutshell will tell you the management aim or the management protocol for hemorrhoid. So grade 1, grade 2, you are rest assured that you can start with conservative treatment. Grade 3, you start with some office procedures. Grade 4, surgery is a must. Okay, so that's the management of hemorrhoid. Now we need to treat the constipation also. How do we treat constipation? First, as I told you, you have to exclude the non-colonic causes or extracolonic causes of constipation by doing these investigations. Then toilet training program, it is very important. You should obey the urges which we have, gastrocolic or defecation reflex. Timely defecation is an important thing. Laxatives like bulking agents, stool softeners, osmotic agents, stimulants, lubricants, and other are to be used judiciously. Now remember, bulk forming agents, they are good, but the problem is sometimes they tend to cause bloating. So 20 to 30 grams per day is recommended, and you gradually increase it. Okay. Now this is the algorithm for normal transit constipation. That means the colon is not at fault. You don't have any secondary causes like cancer, hemorrhoid, or others. There, what you do, you start with high fiber diet. Some milk of magnesia can be added. Then you add stimulant laxative. If there is no improvement, the recommendation is you go for polyethyl glycol. If it doesn't respond, you go for lubipriston. Lubipriston is a chloride channel enhancer, which will at end of the day will act as a osmotic laxative. Okay. Now, slow transit constipation. Slow transit constipation means your colon is not moving properly. So colon is at fault. How do you manage that situation? Slow transit constipation, how you have diagnosed it? You have to do a colonic transit time study. Okay. By doing that, if you have a low or slow colonic transit time, we stamp it as a slow transit constipation or colonic inertia. So you can give a trial of fiber supplements, laxative for 6 months. If there is improvement, that's fine, continue the same. If there is no improvement, then what you do a small bowel transit study also, just like the large bowel transit study, because there can be a pan constipation called the small bowel and the large bowel both are not moving. In a situation like paralytic ideas, when you have hypokalemia, the bowel is not going to move, so there is no role of surgery if the small bowel is involved. So if you have a normal small bowel but your large bowel is at fault, then we have a role of doing some surgery. What are those surgeries? Subtotal colectomy. These look big, but believe me, they do have role if you can diagnose a slow transit constipation properly, and they will give miraculous result. Okay. So a subtotal colectomy with ileorectal anastomosis, subtotal colectomy with ileosigmoid, these are all based on actually the level of the colonic inertia involvement. It might be so that the whole of the colon is involved or a part of colon is involved. If a part of colon is involved, we can remove that part only. Okay, and we anastomose proximal and the distal end together. So the diseased portion is gone and the constipation will subside. Okay. Now, pelvic outlet obstruction. Believe me, this is the most neglected part of the constipation. Okay, and because we often fail to diagnose the pelvic outlet obstruction. As I told you, you first, in a patient with constipation or bleeding PR, you do a colonoscopy. You have excluded the secondary causes or structural causes. Then you do a colonic transit time. If it is normal, okay, then still your constipation is persisting, then you suspect pelvic outlet obstruction. You have to do two investigations, at least a difficography, to diagnose pelvic outlet obstruction. How do you treat it? You put the patient on biofeedback mechanism, because sometimes if the patient is having puborectalis paradoxical contraction, this can be improved by doing biofeedback therapy to these patients. Okay. Sigmoidectomy and star procedure are the procedures which are reserved for certain situations like rectocele, or when you have a rectorectal intersusception. These are nothing but the stapled hemorrhoid procedure, as I told you, but they are used at multiple times. This extra portion of the rectum which has popped into the anterior part, that is taken out selectively. Okay, and this can cure the situation. So obstructed defecation, rectocele, and distal rectorectal intersusception, these are the three situations when they are diagnosed properly. Star procedure is a surgery which is done nowadays with a stapler, and it will cure the situation. Okay, so to summarize the whole thing, to summarize the constipation part, your take home should be, you need to diagnose a constipation. As I told you, the Rome 3 criteria is the standard criteria for constipation. Most of us are constipated, but we don't diagnose it properly. Okay, so diagnosis of constipation is the utmost important thing. After you have diagnosed it, you exclude the structural causes by doing a colonoscopy. Barium enema or barium double contrast barium enema is not routinely done, so colonoscopy is fair enough. Okay, 6 months of conservative treatment if your colonoscopy is normal. So any patient with constipation, you start off with conservative treatment, do a colonoscopy. If colonoscopy is normal, wait for 6 months. Even after 6 months, your patient is still complaining of constipation and significant constipation and fitting into Rome 3 criteria, 3, 4, 5 parameters are positive out of 6. Then your patient is having constipation, and you must do 3 investigation: colonic transit time, difficography, and manometry. These 3 important investigations are to be done to rule out a slow transit constipation or a inertia, colonic inertia, or a pelvic outlet problems. Remember, surgery do have role in these patients of pelvic outlet obstruction or a colonic inertia, and they will respond very well to surgery along with the conservative treatment. Regarding bleeding per rectum and hemorrhoid, again, remember the grade of hemorrhoid and the secondary causes of hemorrhoid are to be diagnosed properly. If you get a patient of hemorrhoid, you just don't examine the patient and you send the patient home with some medication. That is not at all done. So you have to at least do a proctoscopy. You can start off with any medication, and you do send the patient to your surgical colleague. If you are not doing proctoscopy yourself, then you will do a proctoscopy properly, because a secondary cause of preventable secondary cause of or a curable secondary cause of hemorrhoid should be treated, should be identified properly. Remember, colonoscopy saves life. Yes, colonoscopy, we don't have a screening colonoscopy government run program, but these are the situations when we can run opportunistic screening. So any patient presenting to you with bleeding per rectum after 40 or 50 years, colonoscopy, you are justified to do a colonoscopy. It is it's office procedure, not that much of painful, but it can save life because it has a potential to diagnose an early colonic cancer. It can also diagnose the grade of hemorrhoid, which will tell you, which will dictate your treatment protocol later on for the hemorrhoid also. Okay, so if you have a bleeding, the topic of today was bleeding hemorrhoid. If you have a bleeding hemorrhoid, if a patient who is actively bleeding and you have stamped the patient as hemorrhoid grade 1, grade 2, grade 3 or grade 4, whatever, then what is your protocol? Remember, check hemoglobin properly and regularly, because I have seen, we do all have seen patients of hemorrhoid presenting to you with severe pallor hemoglobin of 3, 4, 5. Okay, so check hemoglobin or see clinically pallor properly. Then you start off with conservative treatment. If it is a grade 1 and grade 2, you can start with and end with conservative treatment only. Okay, if the patient is having grade 3 or grade 4, then surgery will be required, but you can buy time for surgery and you start off with medications. It has been shown that the flavonoids, if they are used perioperatively before, during and after surgery, they will give a better outcome. So diagnosing the situation properly, diagnosing the grade of hemorrhoid properly, and timely surgical intervention is going to give maximum relief if you think about the patient's perspective. Okay, so to conclude, don't hide constipation, don't hide hemorrhoids and bleeding PR, and don't hesitate to put your finger inside the rectum of the patient to do a proctoscopy or a digital rectal examination, because if you try to hide it or if you don't see it, later on it's going to flare up and will give you much trouble than you have anticipated beforehand. So again, thank you very much. Thank you, Sun Pharma, for giving me the opportunity to talk in front of this august audience. Thank you very much. Over to you, Dr. Abbas.
Thank you very much, sir. It was an excellent message. The message is colonoscopy saves life. And yes, and if there is a hemorrhage or if there is a bleeding and the patient is having a constipation and having a red flags, we must take a chance to investigate patient by colonoscopy, and definitely it will help the patient. Very strong message, sir, from your presentation. Now I request you to please stop sharing your presentation so that I can take a couple of slides on aldosterone. So viewers, I will take only next 7 minutes and discuss about the aldosterone. Yes. My slide is visible, right, sir?
Yeah.
Yeah. Okay. So I am happy to announce that we have launched a brand called aldosterone, which is useful for the management of hemorrhoids and chronic venous disease or chronic venous insufficiency. So what is the composition? Composition is each film coated tablet contain micronized purified flavonoid fraction. We call it as a MPFF. Now it is a flavonoid. It is derived from raw oranges, and the main flavonoid which is derived from these oranges is the hesperidine, and from this hesperidine diosmin is purified. So hence it is a purified flavonoids. And since the size of the particle or the flavonoid is reduced to less than 2 micrometer, it is called as micronized. So it is micronized purified flavonoid fraction. Now why we micronize it? Because it increases the bioavailability to almost 58% from 33% if you are using non-micronized flavonoids. There are two formulations. One is 500 milligram and another is 1000 milligram. Each formulation will have 90% of diasmin and 10% of hesperidine. So it will be more effective as compared to diasmin itself because it is also having the component of hesperidine. It is indicated in the treatment of chronic venous insufficiency or chronic venous disease for the treatment of venous ulcer along with other adjuvant treatment, acute hemorrhoidal attack, and chronic hemorrhoidal disease. You can use it, and it can be used as an adjuvant to surgery and other procedures. So before surgery, if patient is coming with complaint of bleeding, you can give this, you can control the symptoms, and then you can convince the patient for surgery, and you can refer him to the surgeon for the complete cure of a hemorrhoids. Now, out of this, acute hemorrhoidal attack is an DCGI approved indication. Rest of the indications are off-label indications in our country. However, they are very well backed by international guidelines as well as a strong evidence. If you look at the dose in venous insufficiency or chronic venous disease, you can give 1000 milligram daily with meals. In acute hemorrhoidal attack, now this is very important that we have to use it in the proper dosage. See, you have to use it 3 grams daily in 2 divided doses for the first days. Now here, some of the doctors, they use 1000 milligram 3 times a day. Some of the doctors, they use 1500 milligram in the morning, 1500 in the evening, and then 2 grams daily following 3 days. So this is a 7-day course. And after this 7-day course, you can continue the treatment for with 1000 milligram per day once daily for a minimum period of 2 months or more at your discretion. So if patient is taking more time to take a decision on the surgery and he wants to buy certain time, you can definitely think of using it for the long period of time. Now, if you look at the pathophysiology, as sir was saying that there are predisposing factors in case of, now this pathophysiology is a common in chronic venous disease as well as in hemorrhoids. In case of chronic venous disease, there is a long-standing, or you can say the person has a long-standing kind of a situation wherein there is accumulation of the blood in the lower part of the body and in the limbs, which gives rise to accumulation of the blood in the vessels. While in case of the hemorrhoids, you'll find that there is an engorgement of the vessel in the hemorrhoidal stump, and which again gives rise to stagnation of the blood in hemorrhoidal stump. When there is a stagnation of the blood, what happens is there is activation of the endothelial cells, which leads to damage to the glycocalyx layer, which is there on the endothelium. And when this happens, these leukocytes, they get adhered to this endothelium, they get activated, and they infiltrate the wall of the vessels, and the inflammatory process sets in. So when this inflammatory process sets in, this inflammatory process is responsible for the fragility of the stump in case of the hemorrhoid. And you will find that in case of chronic venous disease, there is inflammatory process, there is an edema, there is a change, skin color changes, and ultimately it leads to the venous ulcers because of the formation of the fragility. Now, in case of chronic venous ulcer, there is a defect in the wall also, so wall dysfunction is also affected. And also there is a venous wall dilatation of the venous wall, which leads to the venous wall dilatation, and further this abnormality is activated. So how this MPFF acts? The main action of MPFF is a venotonic action. So it contracts the veins and the small vessels, small venules, and because of which what happens is the blood is, the venous emptying time is reduced. So venous emptying time is increased, so this hemodynamic abnormality is corrected. In addition, it also has an anti-inflammatory and antioxidant property. It do not allow these WBCs to attach to the endothelium, and thus it reduces the activation and infiltration of the WBCs, and it takes care of the inflammation, which is the main pathophysiology in hemorrhoids as well as in chronic venous disease. So it bang on directly on the inflammatory property or inflammation, which is responsible for fragility both in case of hemorrhoids as well as in case of the chronic venous disease. So here in nutshell, the same thing has been explained. They have venotonic action, so they decreases the venous emptying time, they are vasculoprotector, they increases the resistance in the small vessel, they reduces the edema, they have anti-inflammatory property, and because of which they normalizes the capillary and they improves the symptoms of CVD, improves ulcer healing, improves pain of the pain in case of CVD. It also improves the symptoms of hemorrhoids, bleeding, edema, pain, etc. It not only contracts the veins, also it contracts the lymphatics, so it reduces the leg edema. Also, it mitigates the venous wall deterioration and the reflux. Thus, it improves again the symptoms of chronic venous disease. Now, as far as absorption is concerned, it does not get absorbed from GIT as it is. It is rapidly transformed by intestinal flora into diosmetine, and these diosmetine get absorbed. It is widely distributed in the body, and there is a slow elimination. And you will find that the diosmetine is rapidly and extensively metabolized and eliminated in the urine. 50% of the unchained diosmine and diosmetine is eliminated in the feces, and the elimination half-life is 11 hours. So basically, it has both urine as well as a fecal elimination. Now, there are certain clinical studies which I will share with you. Now, in this study, we wanted to know whether study the efficacy of MPFF in the treatment of symptoms of acute hemorrhoids. So we took 100 patients. It was double-blind placebo-controlled study. One group MPFF was given, another group placebo was given, and we have seen the improvement in the symptoms at the end of the treatment. You can see within day two of the treatment, by day 3, 30% of the patient will show improvement in the symptoms, or the improvement and the disappearance of the symptoms. Day 4, 48%, and within 7 days, you will find that the symptom will improve in almost 92% of the patient. And you can see, if you talk to them, the patients will say, 77% of the patient will say there is a decreased duration of the hemorrhoidal attack, as well as there is decreased intensity of the hemorrhoidal attack as compared to the previous attacks. And overall satisfaction, you will see 84% patients will show satisfaction and 86% of the clinicians. So author says that the MPFF, it resulted into quicker and pronounced relief from signs and symptoms of acute hemorrhoids as compared to placebo. Now, in that case, in this study, we wanted to see the how early the bleeding can be stopped, and how early the bleeding can be stopped, and whether the relapse is prevented. So here we have studied 100 patients. They were double-blind. It is a double-blind placebo-controlled study. One group was given MPFF. 50 patients are given placebo. This treatment is given for 7 days for acute phase, and in continuous phase, patients were treated for 90 days. You can see here 1000 milligram is continued for 90 days, that is 3 months. And we try to find out the number of patients in which there was no bleeding on day 3, and number of patients in whom relapse of bleeding was prevented. You can see by day 3, 80% of the patient, there will be no bleeding. It's a commendable response. And within day 2, 44% patients will have a no bleeding as compared to placebo. And by day 4, almost 92% of the patient, there were no bleeding. So it can rapidly controls the bleeding of the hemorrhoids, and thus you can give confidence to the patient, and you can try to counsel them for further treatment. Relapse of the treatment, you will find that if you continue this for a 3 months, you will find that the relapse of bleeding is prevented greater in MPFF group by 18%. So 18% more patient had no relapse as compared to placebo. So it is effective in quickly stopping the bleeding of the internal hemorrhoids non-invasively. Now this is the study wherein they have compared the MPFF with laxatives and banding. So you can see it is a randomized study. There were 3 groups. In one group, MPFF and fiber was given. Another group, fiber was given. In third group, banding and the fiber was given. So the total treatment they continued for the 3 months. See what is the result. Time needed for rectal bleeding to stop. It stopped in 3.9 days in MPFF plus fiber, while in case of just fiber, it took almost 10.6 days. So some of the doctors may feel that yes, we can just relieve the constipation and the bleeding will stop. No, if you don't use MPFF along with the fiber, the bleeding will stop, but it will take some longer time as compared to the MPFFN fiber. And banding, it takes almost 5.6 days to stop the bleeding. As sir has said, we do the banding, and the stump has to undergo necrosis, then it sloughs off. So it takes some time. So this is how the MPFF and the fiber stops the bleeding within 4 days. And recurrence, you see, after 6 months, you will find that it was seen in 5.1% in MPFF group, 21% in banding and fiber groups, and 12% in the fiber group. So the recurrence also can be reduced if you use fiber along with the MPFF. So MPFF supplement accelerates the relief from the bleeding in the internal hemorrhoids, and it will have an important role when we do not have, especially physicians and the surgeon, they do not have expertise of doing banding in the patients of hemorrhoids. So this will be a very handy for them to control the bleeding. Even for the surgeon, when patient is asking for some time to take a decision on the hemorrhoids. Now here in this study, we have studied the author has studied the effect of MPFF on the incidence of secondary hemorrhage after hemorrhoidectomy. Now, after hemorrhoidectomy, patients were randomized into MPFF group and the control group. So, in both the group, fibers were given. So, what they studied is the assessment was done by independent blinded observer, and they have studied post-operative secondary hemorrhage was recorded for 15 months. And you can see the hemorrhage was seen in almost only 0.9% in MPFF group and 6.1% in the control group. So the secondary bleeding also can be prevented if you are using this during the surgery and the after surgery. So it significantly reduces the risk of secondary bleeding or the hemorrhage after effective hemorrhoidectomy. Now, this is the study in pregnancy, of course. Now, here they have given it 8 weeks before the delivery. Of course, in the 3rd trimester, this medicine was given, and patient was followed for 4 weeks after the delivery for the improvement in the symptom. You can find that the symptom scores were improved related to baseline in almost 66% of the patient within 4 days. Within 4 days, you will find that the symptoms will improve, and there will be a significant relief from the symptoms within 7 days, and the rectal inflammation will reduce in 46% of the patient. And relapse, if you see, as compared to the baseline history, frequency and duration of the relapse of acute hemorrhoidal symptoms was significantly reduced in the maintenance treatment. And in antenatal period, relapse occurred in 53.6% of the fewer patients. So in short, it is safe and acceptable and effective treatment in hemorrhoids of pregnancy, especially in the 3rd trimester. Now, this is the meta-analysis wherein there were 10 clinical trials, almost more than 1,000 patients, which says that MPFF clearly controls the bleeding in the patients of hemorrhoids. Now, these are the recommendations of ACRSI, which sir has also told that MPFF is used in the medical management of hemorrhoids as a first-line treatment in grade 1 and grade 2, and selected minor cases in grade 3 of the hemorrhoids. It can be used as a maintenance therapy as a 1000 milligram daily for 2 months or more if a patient takes some more time for taking the decision regarding surgery or he is not getting improvement in the symptoms. MPFF also serves as an adjuvant for procedures in the surgery. You take it before surgery, you continue during surgery and post-operatively. So before surgery, it will give time to the patient. During surgery, there will be a reduction in the edema, and you will get a clear field for the surgery. Post-operatively, it will improve the quality of recovery from the surgery. And of course, it will prevent the secondary bleeding when you are using it in the patient who are undergoing surgery, whether it is a day procedure or whether it is a hemorrhoidectomy. Now, okay, these are the in nutshell about MPFF. Controls the symptoms, bleeding, pain, and discharge. Safe and effective in pregnancy. Prevent relapse in chronic hemorrhoids. Recommended by ACRSI as the first line, and it can be used as an adjuvant to surgery. Now, there are certain studies in chronic venous disease. Due to positive time, I will quickly go through this study. Now, here is the meta-analysis in the patients of CVD. You can look here. The patient has been given the medicine for the 2 months, and there were almost 1692 chronic venous disease patients, and you will find that MPFF is superior to placebo in reducing almost every symptom of chronic venous disease, which is the pain, heaviness, fatigue, feeling of swelling, tightness, cramps, etc. So MPFS is highly effective in improving the leg symptoms and edema and quality of life in patients with CVD. Now this is the meta-analysis which talked about venous ulcer healing. Now see here there were five studies, 723 patients. Venous ulcer is to the tune of 4.5 centimeter, and the conventional treatment was given along with MPFA 500 milligram BID, that is 1000 milligram per day, and it is given for 6 months. You can see healing of ulcer within 6 months is in 61.3% as compared to 47% in control group, and you see the healing is seen in within 16 weeks, where here the healing is in 21 weeks. So 5 weeks earlier healing is a very important aspect in MPFF. So venous ulcer healing is accelerated by MPFF treatment, and it must be considered in the treatment of venous ulcer healing. Now the relief study, it talk about the long-term use. You can see 4,527 patients. They were given 1000 milligram per day, and duration is 6 months. You can find that whether patient is having a reflux or without reflux, in the chronic venous disease, there is an improvement in all the symptoms, pain, swelling, heaviness, cramps, etc. All shows improvement. So evolution of the clinical symptoms and signs show significant improvement from day to day 180, 6 months. And you can see the quality of life, the global index, or the life by global index, or you can say civic score, we call it as a chronic venous insufficiency questionnaire. It shows improvement in both the patients, both the group, whether there is a reflux or there is no reflux at all. So relief study proved that the long-term treatment of MPFF is useful for the sustained release of the patient with CVI. Similarly, here is a 1-year study wherein patients were given 1000 milligram for 12 months, and you will find that all the symptoms, whether functional discomfort, calf discomfort, circumference, or supramalleolar circumference, all shows improvement in the MPFF group. And you can see the safety overall assessment of efficacy is almost very good in 58, almost 93% of the patient. And you will find that only gastralgia, that is a pain in the stomach, is seen in 7 patients. So it is very well tolerated and effective till the 1 year of time. Now, this is important, wherein in an Indian consensus in CVD, which says that it is the most studied venoactive drug and is strongly recommended in all stages of chronic venous disease. Now this is important, very strange or interesting, you can say. Due to its venoprotective action, it has antioxidant property also. We recommend MPFF even in patients with only symptoms or a case of suspicion of CVD. So they say that empirically also, before you diagnose CVD with the Doppler study, you can continue the MPFF for these patients. So these are the various guidelines, national and international guidelines, which recommend MPFF in the treatment of CVD. And you can see tolerability to the tune of 10% of the patient will complain adverse event, whether you give it for the long time up to 1 year or you give it for the 7-day treatment. And the most common adverse event which you can see is a GIT adverse event like abdominal pain, epigastric pain, nausea, dysphagia, vomiting, diarrhea, etc. is possible. Now, special population, adult and concomitant illness, yes, it is well tolerated. Hypertension, atherosclerosis, diabetes, neurological or psychological illnesses, it can be given. Pregnancy, it has an acceptable use, especially in the 3rd trimester. Breastfeeding, there is no data, so we do not suggest. Now, as far as liver impairment is concerned, the animal studies have shown that it has a hepatoprotective effect. However, since these are the animal study, we advise a caution when you are using it in the liver patient. In the renal failure patient, we do not have any studies, so we do not recommend or not tried or tested in the patient suffering from renal failure. Drug interaction, as such, there are no formal studies performed, but there is a huge post-marketing data, and it has been observed that there is no drug-drug interaction. Now, comparison with 2 important drugs which we use it in the treatment of hemorrhoids, that is Euphorbia prostata. We call it as a Thank-OD, which is available as a Thank-OD in the market. You can see what it causes. It causes a dry mouth, and it alters the coagulation profile. So caution is advised when patient is on anticoagulant or antiplatelets like clopidogrel or clopidogrel, prasugrel, or you can say aspirin or say oral anticoagulants if you are there. The chances of bleeding increases when this drug is used along with these patients. Patients who are taking this anticoagulant, especially elderly patients who are having the cardiac abnormalities. When it is a calcium, as far as calcium dobicelate is concerned, it causes agranulocytosis, and the evidence of its use in hemorrhoid is very minimal. Of course, when it comes to the pregnancy, it is only MPFF which is a safe, which can be considered. So aldosterone contains MPFF 500 and 1000 milligram. It is useful in acute hemorrhoids, chronic hemorrhoids, and chronic venous disease. In hemorrhoidal disease, it quickly controls the symptoms, bleeding, edema, pain. It prevents relapse in chronic hemorrhoids. It is safe and effective during pregnancy. It is recommended by ACRSI as a first-line therapy, adjuvant therapy in surgery, and maintenance dose for 2 months or more. In CVD, it is highly effective in controlling the leg symptoms, accelerates the venous healing 5 weeks better. Relief study has shown that it can be given up to 6 months safely, and it is strongly recommended by national and international guidelines and Indian consensus, which says that it can be used in all stages of CVD and suspected cases of CVD also. So it is most studied among the flavonoids and recommended by national and international guidelines. Calcium dobicelate associated with agranulocytosis, euphorbia prostata, alters the coagulation profile. So you have to be cautious when you are using it in the patient who are taking anticoagulants and antiplatelets. Thank you very much for your patient listening. Now, sir, without wasting time, I will take the questions which we have got from the audience.
All right.
Yes, sir. Aldosterone. Sir, meanwhile, I'm seeing the question.
Right.
While you are discussing about the constipation, you talked about that there should not be a habit formation with laxatives and the fiber. So will you please elaborate, because this is a common fear a GP or a doctor when I'm sitting in the OPD I have, and patients do also ask us whether I will keep on taking it for a long time, will it be a habit forming for me? So your comment on this, please.
Yeah, not really. So habit forming, if you are giving lactulose or a isopgol bulking agents usually they don't form habit forming. But with lactulose, you can still continue with for years. Okay. So they are safer. But what I say, there is a psychological dependence which can develop even after 6 months, even after it may not develop even after 2 years. Okay. So it's better to avoid a long-term use of lactulose, which forms a habit formation program.
Okay. So fiber we can continue rather than.
Fiber you can continue.
Okay. Yes, sir. Now, sir, Dr. Sundar Rao from Kolkata, he is asking why there is often a recurrence of hemorrhoid after operation. That is his question.
Yeah. So that is an practical question, I think.
Yes.
So,
yes.
Yeah. Recurrence. See, nowadays, if you miss one hemorrhoid and you operate on other two, previously we used to do Milligan-Morgan operation. So Milligan-Morgan operation, you cannot remove all 3 hemorrhoids at same time, because if you remove all 3 in the same time, the anal mucosa is going to be damaged and the patient will develop stenosis later on. So intentionally, we do 1 or 2 hemorrhoidal surgery at a time. If you are doing Milligan-Morgan, that is the open surgery. So the recurrence, the third one, suppose I take out the 3 o'clock and 7 o'clock, but I keep the 11 o'clock intact. So this 11 o'clock is going to recur. It's actually not a recurrence, it's a new hemorrhoid which is being formed. This is number 1. And number 2 is, when you are doing a stapled hemorrhoidectomy, the chance of recurrence goes down because you are taking a circumferential clearance. Okay, so here the recurrence becomes little lower. But remember, most of the cases, the recurrence or rather a new hemorrhoid appears just because we don't remove the other one, because that is not recommended. Okay.
Yeah. So basically, it is a new hemorrhoid which is
Yeah,
coming out rather
yes,
than
the new
which we
hemorrhoid.
have not operated. Right. Right, sir. Now, sir, he also has one more question, Dr. Sundarrao. He's saying, is there family history that predisposes hemorrhoid?
That's interesting. Now you see, now you see, at the age of 50, 50% will have hemorrhoid. So it's actually very difficult to stamp it as of now. There is no gene being identified which will tell you that this particular gene is responsible for, as we have for colon cancer. 10 to 15% of colon cancer is genetically predisposed. Okay, either familial or hereditary. 80 to 85% is sporadic. So as of now, there is no gene being identified. But yes, there are some people, there are some families who are chronically constipated. Everyone in the family is constipated. So maybe there might be some familial predisposition.
Yeah, probably, sir, their diet habit, because
Diet habit,
in the
yes,
home.
yes. It's actually related with the diet habit.
Yes, so they have same lifestyle in the home. So probably one of them is constipated. It means everybody will be constipated in the home, provided they are having the similar kind of a yes. Now, sir, Dr. Tapas Kumar, he is asking, Tapas Kumar Chatterjee is asking, how practical it is to go for difficography and other in our setup.
Yes,
I mean, do you really do it? I mean, do you really do it in a hospital?
Right, right. I mean, yes, we do it. So I was expecting this question because the colonic transit study and difficography or anal manometry, these are done in selected setups. Okay, but believe me, it's not that difficult, but it is done. So as I told you, the difficography is the last investigation you do. So first, if you are suspecting a primary colonic cause, that means either a colonic inertia or a pelvic outlet obstruction. So you do a colonic transit study. Okay. So if your colonic transit study is normal, then only you go for the difficography and aneurysm. Okay. So first study you do a colonoscopy. If you find something, then your job is easier actually. So you treat that particular cause. If you don't find anything, they will then you put the patient on 6 months of fiber supplement and all this. Then if the patient responds fine, you don't have to do any further investigation. But if your patient still complains after 6 months, the patient complains of constipation and significant constipation, then you have to perform these trials. Chronic transit study is the first study in this segment you do. If that is normal and patient is still constipated, then you go for difficography. But yes, there are centers who are doing not only a fluoroscopy guided difficography, they are doing MR difficography. There are some special MR machines which will allow these tests to be done.
So basically, sir, I'm very curious to know now and how it is really done. I mean,
it's actually for a fluoroscopy guided. If you are doing a fluoroscopy, the barium dye is instilled inside the rectum via catheter. Okay, so you fill the rectum first with the dye. Then you take a picture. You will see the rectum is completely dilated with dye. Now you ask the patient to push. Okay, when you ask the patient to push, you take another film. So it's actually fluoroscopy which is taking continuous multiple films. So you ask the patient to push, there will be a commode. This fluoroscopy, the whole system, this difficography system is centered with a commode. Okay, so you have films there. You ask the patient to defecate there, and the fluoroscopy will take serial pictures.
Okay, got it, sir. Got it. Thank you very much, sir, for that answer. Right. Then, sir, Dr. Tapas Kumar is also having one more question. He's saying, is laser superior to all forms of other treatment?
No. No. One single answer is no. Laser is another form. I have intentionally not included the surgical part in depth. There are a lot of surgical procedures. Stapled hemorrhoidectomy and Milligan organ are the gold standard for that. We have DG Health. That means Doppler guided, you ligate that area. We have Shivade procedure developed by a person from Bombay. So you have laser also. Laser, what you do, the principle is same. You are going to burn the apex of the hemorrhoidal plexus, so that it will cause coagulation of that part, and the hemorrhoidal supply will go down. Okay.
Right. Right. Perfect, sir.
But
Uh,
laser has got a commercial part rather than its original effect. Sometimes I have seen people doing normal surgeries along with laser, because you see, when you are doing surgery inside the rectum, nobody is going to see what you are doing. They are giving a note of
exactly.
laser. Yes. So yes, of course, laser do have role in fissures. If you are doing a lateral sphincterotomy, if you're doing it with laser, it's really painless, and it is really not going to put any scar there. Hemorrhoids, grade 1 and grade 2 can be tackled by laser. Circumferential hemorrhoids, grade 3 or grade 4, it's very difficult to tackle with laser. You have to add
Right.
any other procedure along with laser.
Right, sir. So what I understand is, in hemorrhoids, there is no one size fit for all. You have to really select the right procedure for the right patient. Right, sir. Just now you spoke about a fissure. So for our audience, I mean, I would like to ask one question, which is very common and very important. If by history, how I can differentiate between hemorrhoids, fissure, and fistula?
Right. So first is fistula, which is completely different thing. It's very easy to identify fistula. So fistula is a communication of rectum or the anal canal with the exterior. Okay, so that's it. That is a fistula by definition. So in a fistula, the patient will have another opening outside the anal canal, through which some amount of discharge, maybe pus, maybe stool, will come out. So discharge of pus or any other content from a different opening other than the anal opening is a fistula. Okay, so fistula is clear. Now we are left with fissure and hemorrhoid. Okay, fissure is always painful. So fissure is always painful. Hemorrhoid may be painless, may be painful. Okay, if you are dealing with an internal hemorrhoid, it is painless. So if you are dealing with a painless bleeding per rectum, without any pain, without any post-defecation pain, then it is not a fissure. So fissure is excluded. Fissure can give rise to bleeding also. But the typicality of bleeding in fissure and typicality of bleeding in piles or hemorrhoid are different. In fissure, you will have streak of blood around the stool. Okay? But in hemorrhoid or piles, you will have spillage of blood. It's like a sprinkle. Okay? So that is one important thing. In fissure, there should be acute pain and post-defecation difficulty. After the patient defecates, the pain remains for half an hour, 1 hour. In some patients, if it is acute fissure, it will remain for 2 to 3 hours. Okay? So fissure is painful, hemorrhoid, and will have streak of blood around it. There will be no severe hemorrhage. Okay, a fissure patient will not present to you with an hemoglobin of 4 or 5. But piles will have spillage of blood. So the pan will be filled with blood. Okay? And in fissure, it is usually towards the end of the defecation, the blood comes out with the stool. And in piles, it can be at the beginning of the defecation, in the middle of the defecation, and at the end of defecation. Okay?
Right, sir. I got it. Thank you very much, sir. Sir, one more thing, that hemorrhoids, internal hemorrhoids can also be a painful. So what is that situation and how I can really take care of it?
Yes. So internal hemorrhoids, when they engorge, when they come down and becomes prolapsed. So this is a situation when there will be severe pain. Okay, so that is why I told you a proctoscopy is very important. Okay, in a patient of fissure, it's the whole thing is in the sphincter. So sphincter will be so tight that you won't be able to see the inside of the anal canal. You won't be able to put your proctoscope in. But in acute hemorrhoid, which is painful, you will be able to do a proctoscopy. You will be able to do a digital rectal examination.
So once you do the digital rectal examination, you can feel the tone of the
Yes.
sphincter,
One of
and
the
you
sphincter.
will, yes, okay. Okay. Uh, Yes, Dr. Khan from Jabalpur, he is asking, hemorrhoid is incurable by medication. Ultimate solution is surgery. Does it can be completely cured by any kind of medications only?
Yeah. So as you were saying, Dr. Abba, so if it is a grade 1 hemorrhoid, possibly that can be completely treated by even some only with dietary modification and with some medication.
Yes,
If it is
yes,
grade 1, it is possible. Some of grade 2, it is still possible, but grade 3 or grade 4, it's not possible.
yes. Okay, perfect, sir. Sir, there are a couple of questions on hemorrhoid, MPFF. With your permission, I can
Yeah,
take
you
those
can answer,
questions.
please. Yes,
Yeah,
please.
Dr. Sundar Rao, no, we have taken that question. Then Dr. Chandidas is asking from Malda, how long do we use this diosmin and hesperidine? So, sir, as I showed in the study, we can use it up to 12 months. There are studies where it has been used up to 12 months safely. He is also, yes. And what are the common side effects? Yes, sir. I talked about abdominal GI adverse event like diarrhea, abdominal pain. These are the possible most common. Some patient may also do nausea. Dr. Dattatreya Das is asking, is there any use of medication in grade 1 and grade 2 hemorrhoids? Yes, sir. These are most commonly recommended for grade 1 and grade 2. You can maintain the patients in grade 1 and grade 2, which do not require surgery unless and until it gets complicated and progresses to grade 3 and grade 4. If there is no bleeding, should aldosterone be used? Sir, I would like your comment also on this. From my side, I can say, sir, it will control other symptoms also like edema, the mucus discharge, which is there, or the pain sometimes if it is there. That also can be taken care with aldosterone or MPFF. So, in my opinion, you can consider MPFF. Sir, your comment on this.
Yes, I do agree with you. So, this patient who is not having bleeding per rectum, then why the patient presented to the doctor? That means he must be having some symptoms. It's if it is not bleeding, then it is an irritation in the rectum. That means the swollen hemorrhoid which is causing the problem. It can have discharge. It can have a sense of fullness inside the abdomen or sense of lump. Yes, flavonoids can have role in this situation.
Sure. Dr. Sarkar from Kolkata is asking, sir, please answer this question. If conservative management help and if there are no organic defect, how long he can continue the conservative treatment in the patients of hemorrhoids?
Yeah. So if your patient is having grade 1 and grade 2, if this patient responds, that means the bleeding stops, patient becomes symptomatically fine, then you can continue with conservative. Conservative means which conservative? You can add flavonoids, and that can be continued, as Dr. Abbas said, for months. Okay. Only dietary modification and lifestyle modification, biofit, that means stool habit and etc., you can continue it for lifelong. There is no issue.
Perfect, sir. Right. Dr. Sundar is also asking about, is there any head-to-head study of aldosterone with pentoxifylline in venous insufficiency? Sir, any comment would you like to have? Because I have not come across any such study.
I'm not aware of any such.
Yeah, but sir, in chronic venous disease, do you use aldosterone and pentoxifylline medication? I mean, some comment on CVD. Anyway, this is out of context of today's topic.
Yeah, aldosterone, actually, I have not yet used in CVDs that much. Pentoxifylline, even pentoxifylline is not that widely used for chronic venous insufficiency. Okay. So if you have a reflux disease, our preference is to go for an ablation, either in the form of Trendelenburg surgery or in the form of an endovenous laser. Here the role of laser is much more in comparison to perianal cases.
Yes.
EVLT.
Right, sir. Sir, we have almost answered all the questions of the audience. One important question, sir, before we can end the session, is that Suppose a patient comes to me, he's suffering from hemorrhoids. He's also a cardiac patient and he's on clopidogrel and aspirin. What should I do? I am sitting in a GP setup. Patient has come to me, and patient is telling me that he's having a bleeding, and he's also on the clopidogrel and aspirin. What action should I take?
Right. So you see, this is a condition where, as you told also, euphorbia prostata is not going to be the drug of choice at all. So if you have a clopidogrel, so that clopidogrel is going to increase the chance of bleeding. So here you start off with a conservative treatment. In any way, you cannot do surgery if the patient is on clopidogrel. So here you have to judge between the discontinuation of clopidogrel and versus the benefit of surgery. So here the drug of choice, I mean the treatment of choice should be a conservative one, and you follow the patient with your cardiologist, see what is the risk of discontinuing clopidogrel and ecosprin. Nowadays we can still continue ecosprin during surgery also, but it is better to stop clopidogrel at least 7 days prior to surgery. So conservative treatment is the treatment of choice in this scenario.
Right. So once again, sir, I will just check if there are any additional questions. Otherwise, we can close the session for today. So, right, sir, we have answered almost all the questions. Sir, on the behalf of Sun Pharma, I thank you so much for such a fantastic, elaborative presentation, as well as your guidance on constipation, strong messages about taking care of the patient, doing colonoscopy when there are red flags are there. That is really remarkable. I will never forget this message from today's session. So thank you very much. And now I invite my my colleague Abir Ganguly to give vote of thanks. Over to you, Abir.
Thank you. Thank you. Let me extend my heartfelt thanks to eminent speaker Dr. Shaumen Dash for conducting this wonderful session and answering the question answer session interestingly. We would also like to thank all the frontline COVID fighters and healthcare fraternity for caring and saving many lives. My special thanks to all the participant doctors, those who registered with us and connected to this live session to become a part of this amazing journey of Aldospin Conclave. I would also like to thank all my field warriors, HO team, and SBU head Amit sir for making this conclave come live for all of us. Thank you once again to all of you. Stay safe, stay healthy. Thank you.
Thank you, Abir. Thank you very much. Technical team, are we offline?
Dinesh, we are offline.